Welcome everyone to our session, Infusion Pharmacy for the C-Suite, Strategies to Elevate System-Wide Care and Growth. On behalf of Becker's Healthcare, welcome and thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. If you have any questions throughout today's webinar, you can type those into the Q&A box you see on your screen. You will find a few engagement tools on your dashboard. Please check out our resources section and also make sure you fill out our session survey. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. Lastly, if at any time you have trouble with the audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we are here to help. It is my pleasure to introduce today's speakers, Jason McCarthy, Senior Vice President and Chief Pharmacy Officer of Corewell Health. Jason McCarthy serves as Senior Vice President and Chief Pharmacy Officer at Corewell Health, a $14 billion health system with 21 hospitals, more than 200 outpatient locations, and Priority Health, a 1.3 million member health plan. In his role, Jason provides strategic leadership for all aspects of pharmacy services, including inpatient, outpatient, mail order, specialty pharmacy, home infusion services, 340B program operations, and clinical care delivery. Also pleased to introduce Amanda Gordon. Amanda Gordon serves as the Vice President of Ambulatory Pharmacy at Bon Secours Mercy Health. She is responsible for developing strategic vision and driving operational excellence across the ambulatory pharmacy enterprise. Amanda oversees a broad range of services, including ambulatory clinical pharmacy practice, population health, hospital-based infusion operations, pharmacy patient financial assistance programs, 340B program system operations, and home infusion services. Finally, Dale Driz, Managing Director, Vizant. Dale serves as Managing Director at Vizant, providing strategic leadership across the organization with a focus on infusion services strategy. In his role, Dale supports business growth and development within Vizant's managed services offerings, partnering with health systems to optimize performance and drive sustainable results. Thank you all for joining us today, and at this time, it is my pleasure to turn the floor over to Dale to begin today's presentation.
Thank you. It's a pleasure to be here this morning. We'll start by providing a high-level overview of the infusion market, and then we'll turn it over to Jason and Amanda so that they can help talk about the patient care model, components to infusion services, as well as how to implement strategically for growth within a health system. And then finally, we'll talk about next steps. What do you need to do outside of this in order to get started into this? And then hopefully have some time for questions at the end. So next slide, please. Thanks. The infusion market is a growing market, and it has been for the last decade or so. We see infusion services similar place as specialty pharmacy was about 10 or 15 years ago. It's really starting to take hold across the country, and we're seeing a lot more specialty therapies come through the infusion service lines. A lot of that has to do with new therapies that are entering the market and the evolution of these products that have been coming into market. A lot of the drivers for infusion are a little bit different than they were back in the 80s when home infusion first started on traditional therapies like antibiotics and TPNs. We're now seeing high-cost specialty meds, and the payers are taking notice. So a lot of those meds are shifting outside of traditional hospital-based infusion locations, and they're going towards lower site of care, whether that's in the patient home or into ambulatory infusion clinics. That's a big impetus to what's been driving this market growth. It's a huge market, about $150 billion, and we're starting to see more and more of that go into the home and ambulatory infusion site areas, with about a 6 to 8% growth year over year. Hospital outpatient departments still serve a really big portion of that business, where we've been seeing more of the traditional oncology medications being shifted out due to their high cost and the ability to manage it in a lower cost site of care. The other thing that we're seeing across the country too is traditional hospital outpatient sites are really reaching capacity levels, and they're constrained within their footprint in the four walls of the hospitals. And so it's a difficult time for them to be taking on more and more of this business as patients get older and age into these chronic conditions. And having alternative sites of care really helps free up some of those spaces, which is truly a patient satisfier as well as a provider satisfier to be able to take on more patients, but potentially in different sites of care. Also, consumer preference has been changing over the years. We've seen a lot of changes since the COVID epidemic back in 2020. Patients are much more comfortable receiving care in their homes, but they also want to have much more convenient care, which means options outside of a hospital, which can sometimes be very challenging to get in and out of. And so patients are really driving themselves to these alternate sites of care, which systems are taking notice from, and they're adding that into their arsenal to be able to help serve patients in the best way possible. And then finally, workforce shortages. Nursing care is still difficult to staff for, as well as infusion can still be very fragmented across health systems. And so there are a lot of nurses across the health systems that are serving in a lot of different capacities. And so having these clearly defined areas for home infusion therapy helps to address some of the workforce shortages, and you can leverage other capabilities within your health system through the pharmacy team or other teams outside of traditional nursing to help support some of the business. This next slide talks a little bit about the growth that I was alluding to earlier. We're seeing a rise in chronic diseases across the country. It's an aging population. And so a lot of these therapies that are infused therapies we're seeing more and more of as the population gets older. We're also seeing those payers really start to accelerate the number of site of care medications that they have on their list of that have to go to a lower cost setting and can no longer be done in a traditional hospital-based setting. And so you can see on the chart here, not that long ago, 2018, 2019, there were under 100 meds in these categories. Now in 2024, 2025, we're seeing upwards of 150 to 160 medications listed on payer site of care lists, which just means you need more and more opportunities to be able to capture these patients outside of your traditional infusion settings, which includes things like pharmacy home infusion suites, in the home setting, or potentially physician-based suites. I talked a little bit about on this next slide how the market is just growing tremendously. We're seeing a lot more treatments coming to market that are infused medications. We are seeing some that are being infusion to oral or maybe infusion to sub-Q, and we'll see that trend continue. But more and more, they're seeing infusion care being a huge part of this business, entering the market with a lot of new therapies starting on the infusion lens. And so you can see in 2023, over 50% of the approved meds were targeted for things in these really high cost specialty therapies, hematology, oncology, neurology, inflammatory disorders that are geared towards a lot of these infusion therapies. Biologics play a big part of this as well. We're seeing that market explode. Biologics is making things a little difficult where payers sometimes mandate certain biologics and where that'll be. But the ability to accommodate those patients and all of their infusion needs is really important. And it's going to continue to increase as some of these medications go off patent. You'll see more and more biologics into the market. Slide, please. Thank you. The infusion marketplace is very competitive right now. It's still a very local market. And so what I mean by that is patients that are on infusion therapy still need to be seen locally. They have to be infused these medications, and they can't do that across the country with a national network like you can with specialty take-home meds, where it potentially could be delivered to you from out of state. With an infusion therapy, the medication can come to you from anywhere, but the actual delivery into the patient has to be done locally. And so what we've been seeing across the country is a lot of competition in local markets with growing opportunities in the infusion space, both on home infusion, which is therapies done in the home, and then in the suite setting, whether that's pharmacy-based home infusion suites or ambulatory infusion clinics. You can see on this slide, there's a lot of companies in this market. A lot of them are regionally based. Some of them are national. Some of them focus only on the suite setting. Some will do home, some will do both. But you can see on the left, they're still dominated by the major players in the market that really receive the majority of it. But what this means is the market's fragmented, and it's an opportune time for health systems to be able to react to it and help maintain patient care within their four walls. And that's really what we're seeing the drive towards. It's a better patient experience within the health system. It's something that they can bring into the market to make for an easier experience for their patients, because as you can tell here, it's not very easy to determine what's the right place to receive infusion care. It's not like a regular retail pharmacy that you might be used to in the market. You see every street corner has a different retail pharmacy. You know what that experience is. Most people don't have a lot of experience with infusion therapy. And so it's very hard to determine where is the right place to go and where are they going to receive the best care. And that gives health systems a massive opportunity to come in and bring that in-house, show them that the provider is tied to their care every step of the way. And you can support them with all of these different sites, whether you have hospital outpatient, ambulatory infusion suites, home infusion, making sure you have that full continuum in order to be able to support your patients is really going to afford them the best outcomes and the best experience. I'll turn it over to Jason now, and he can talk about enhancing the patient care model and access within health systems.
Thanks, Dale. I appreciate it. Yeah, over the next couple of slides, I think we're gonna, spend some time talking about how to improve some of patient outcomes through a seamless connected journey and expand access and ultimately improve the patient and the provider experience. So a little bit about me, just to build on kind of what was shared earlier. I lead pharmacy services for Corewell Health. We are a Michigan-based health system. We are kind of Corewell as the byproduct of an integration of two health systems started back in 2022. So merger between Beaumont Health and Spectrum Health. So today we sit at around 65,000 team members, and we also have our health plan, Priority Health, which covers about 1.3 million lives, 21 hospital facilities across the state. And as for pharmacy, as mentioned earlier, specialty pharmacy, inpatient, outpatient, we have 11 retail locations, home infusion, and, just shy of 2,000 team members in the pharmacy structure. So why don't we jump to the next slide? And let's talk about, this is a sample of what infusion looks like at Corewell. So hopefully this will look familiar to many of you. I think Amanda and I were joking that we probably all use the same contractor or construction because hospital infusion areas look eerily similar, but they all come in different shapes and sizes. And I think one of the things as you think about your infusion footprint as a health system leader, there is no one size fits all. So whether it's a couple of chairs, whether it's an expanded infusion center, I think the important message is this is an area of opportunity that should be considered and should be explored. Overall, when you think about infusion as a site of care strategy, there's a couple parts and pieces of it. So the first thing, or I think one of the main benefits, is really around optimizing supply chain, being able to buy products at the lowest price point, take advantage of 340B opportunities, and then navigate the best place for patients to receive that care. So if you kind of think about the three buckets of where infusion is provided today, there's physician offices, which most of us are very familiar with. That includes freestanding infusion centers, HOPD models, which you saw some pictures of earlier. And then I think where we're going to spend a lot of our time today between myself and Amanda is really on pharmacy-based infusion services. So not only home infusion, but also the expansion into ambulatory infusion suites. You heard Dale a few minutes talk about payer restrictions, different changes in the marketplace, and patients having multiple choices, but also not knowing where to go to receive their infusion services. So as a health system, there's a real unique opportunity here to capture those infusions, keep them within the four walls of the health system to improve the patient experience and ultimately improve some of the financials that we see within the organization. Tied to that, naturally, before we move on, I would say tied to that is naturally specialty pharmacy. So being able to have that linkage with your specialty pharmacy, depending on where a patient might want to receive their infusion, having your specialty pharmacy being able to coordinate those fills through white bagging, et cetera, I think is also another unique linkage here in the infusion supply chain. And then finally, what I'll probably spend the next two slides kind of talking about is really the underpinning of all that and what I would see as best practice to help navigate and facilitate that coordination through the different sites of care is a centralized med access team. I think that will provide the most benefit to the patients, to the providers, and really can help to unlock some of the financial value that health systems are looking to create. Next slide. So here's what it looks like today. So the journey itself is relatively fragmented, right? In the earlier days, you heard Dale talk about the complexity over time. It started with you went to the provider, you received a prescription or referral, you took it to the pharmacy, you got it filled, and then, that was it. You would just return for your refills, and it was a very straightforward process. As medications have gotten more expensive, the complexity has changed, the authorization process is more difficult, and with more and more payers dictating where these medications can get filled, really the two folks that are left in a continuous back and forth are really the provider and the patient, right? The patient having difficulty navigating where to get their prescriptions filled, navigating the authorization process, and ultimately it becomes an administrative burden for the provider to have to figure out which payer pays for what, where do I need to send the script, and then as we've seen over time, formularies change quite frequently. They're not usually one and done. And so while a product might be covered today as a preferred product, that can change next quarter, next month, and then it becomes another set of work for a patient. I think what's important here to think through is where we are in our journey is really around the ambulatory infusion suite. So we have a good HOPD process, we have home infusion, but I think AIS is kind of the next tranche of where we're trying to explore. So that now creates multiple avenues for patients that this med access team can coordinate. So select the authorization, understand where the prescription or the infusion can be filled, and then schedule with the patient as to what's convenient and best for them, whether it be in the home, whether it be in a suite. If HOPD works and is approved, it then removes that burden from the payer, from the provider, excuse me, and then makes it seamless and easy for the patient. And ultimately, what we think that will result in, and we're seeing that result in, is continuity of care, reduction in additional treatments and labs because of disruptions, better patient satisfaction across the board for the provider and the patient. So I would say centralized med access, best practice to help move forward an infusion strategy, depending on where you are in your journey and your infusion options. There are multiple players in the market spaces, as Dale commented on, but building out those additional legs of the stool to keep patients within the system, we think is the best next step for patient experience and also to improve overall financials for the organization. So from here, I think after kind of setting the stage about kind of the front end, if you will, about how to get the patients through the door, I'll turn it over to Amanda to kind of talk about what she's working on in her system and how she's building out the other parts of her strategy.
Great. Thanks, Jason. Happy to be here. Thanks for having me. I'll start with a little primer about Bon Secours Mercy Health. So we are the 5th largest U.S. Catholic healthcare system and the 5th largest, and the largest not-for-profit provider in Ireland. We have more than 1,200 sites of care in 50 hospitals across 7 U.S. states. We also provide more than $500 million in annual community benefit across our 5 U.S. states. We have 3,000 providers in the U.S. and 450 consultants in Ireland, and over 660,000 total associates. So if you talk about confusing and a complicated healthcare system, we definitely bring the multi-state strategy to the front of that equation. So today, I'll really spend my time talking about how we've tried to white glove that patient through navigating that for the betterment of the patient outcome and also the health system. Next slide, please. All right, so I think the theme of today is really going to be about having an omni-channel strategy. Jason outlined it really good in his earlier in the presentation as he talked about what are all the different options for a patient to receive a specialty med within a healthcare system. So I call this kind of our health and our specialty medication infusion pathway. And this is how we think about guiding our patient through. With that, I really want to talk about the pharmacy footprint and Bon Secours Mercy Health Pharmacy and how we walk the patient through each of the instances of where to receive a specialty medication location. So we have Harness Health Pharmacy, which is our branded Harness or our branded pharmacy chain. We have 30 retail pharmacy locations across 4 states. We also have a central hub for a home delivery pharmacy and 2 locations for specialty pharmacy. We did implement our home infusion strategy within the footprint of our existing specialty pharmacy. So they're operated under one pharmacy license, and we really leverage some of their central processes, the call center, their logistics and ability to cold ship across 25 states. We leverage all of that so we could start our home infusion operation sooner, and we didn't have to build from scratch. We also have opened up a home infusion run ambulatory infusion suite, which I'll preview in a couple of slides. And this is all to augment and complement that existing hospital-based infusion center. So our footprint currently includes 50 different locations to receive infusions. We see about 27,000 patients annually. We also have a smattering of physician office infusion centers. So that could be either freestanding or it could be within the provider's footprint. So if you take a look at that slide, this is kind of how we guide patients through that continuum. So we also focus on that central med access portion for both infused and self-administered specialty meds that Jason talked about earlier. So that's the pharmacy intake and specialty pharmacy liaisons. Right there, we work through any payer barriers and care navigate the patient throughout their journey because it is a complex and fragmented process. And then the pillars are really the different locations to receive your infusion. On the left-hand side is the hospital infusion. We know that that's the safest place to receive your infusion, but it's also the best reimbursed. So if possible, we usually try to have our patients be infused there. If that's not possible, we try to meet them where they are and where their payer requests at an ambulatory site, whether that's a physician infusion, a home infusion, traditional in the home, or a home infusion suite. And then on the right-hand side, we will attempt to fill their medication if it's a carve-out through a pharmacy benefit and they would like to be infused in the hospital. We will clear bag that through our own specialty pharmacy. And then on the bottom, really the foundation is we support these patients with their pharmacy financial navigation program through every step of the way. Jason mentioned a couple of different instances of how treatment therapy could be chosen based on what medication or financial assistance is available. All of these meds are extremely taxing, and you need to make sure that in order for the patient to get the treatment and complete their therapy, they have to be able to afford it. So having pharmacy or a comprehensive financial navigators or a financial support system is crucial to making sure this service line is a success. What we see from this omni-channel strategy is really enhanced network integrity. We think of our infusion service line in the same manner that you would any of the other clinical subspecialties, and network integrity is important. Our CMO said to me the other day, you can't guarantee quality if we're not able to provide that service for the patient. And so that's really something we try to abide by, is how to, at all points, do we keep the patient within our health system, so at least they know they have that patient care portal and their providers have that care documentation. When we send patients out of the health system, often we'll have patients come back for a checkup appointment and not have received their infusion. And that's really not good care. That frustrates our providers and is not doing the best service for our patients. We also know that as we care navigate patients, they feel supported and they feel confident in the care that we're able to provide. Patients, especially as healthcare becomes consumer driven, are going to go where they have the confidence, where they have that high touch communication. So that's a big satisfier. So here's a couple fun snapshots of our central home infusion pharmacy. So you'll see production floor, clean room. We do have redundant clean rooms. We have our conference and our call center. And then also, again, just a picture of our production warehouse floor where we do a lot of the packing and the shipping out to all of our services and all of our service footprint. Next slide. And then this is an example in our Lima, Ohio market where we implemented a ambulatory infusion suite. So I do want to take a moment here. This is not a new concept, and a lot of health systems are really investing in the home infusion operated ambulatory infusion suite. So this is an option where maybe a patient doesn't feel comfortable having treatment in their home. Some of the specialty and biologic infusions are multiple hours. So if you think about a nursing productivity, a patient satisfaction, sometimes patients want to come in and receive that healthcare within a facility as opposed to their home. We've made this in close proximity to some of our specialist offices. It's right in the medical office building. And we're also able to leverage a float staff nursing pool from our existing infusion center. So if you think about nursing productivity, this is also a good option if you are in a geographic area that doesn't have a high penetration of home health services. And especially if you think about the niche biologic services, you don't always have the home health agencies that are able to do the specialty medications. It requires them coming to the home, starting a new line, and staying there for multiple hours. So it's kind of a win-win-win. The other thing is this was pretty low capital expenditure and a pretty low startup time. I think it took us 3 months and approximately $30,000 to $40,000 in capital expenditure to really just convert what was already an existing provider office into this pharmacy home infusion space. So the other question that I get from some of my executives and some of my managed care professionals is, how is this billed? So we prep the drug in home infusion, we courier it over or deliver it in a pack, just as we would to a patient's house, and it's billed through home infusion. So your managed care negotiated contracts for home infusion are leveraged here, so it's no additional contracting. We did get ours accredited through our home infusion accreditation agency. We sent courtesy notifications to some of our payers, but really you're just putting a place of service, or you're putting a modifier on an existing billing service. So this is, if you already have your home infusion contract, you should be good to go for this. So this is also a nice option in certain geographic areas and for certain subsets of patients. So if you're going to focus on something, you know, Jason and I have talked about previously, focus on the front end. This is really where you have the biggest bang for your buck in terms of positively impacting patient experience and then also your financials. So what we saw in our terms of our primary outcomes is a reduction in denials and also sending patients outside of the system. We saw better recognition of any of the payer challenges up front in the process so we could care navigate the patient. In terms of other KPIs, we looked at how many referrals did we triage, and then how many even were we working, but we were still getting denials on, and what could we do there? And then we also looked at what are the clinical denials that we were able to overturn. So far, we've seen a really positive experience in our pilot markets, and we plan to expand that system-wide. So I think at this point, we can really take a step back from what Jason and I did and really focus on, what do you think about if you're going to think about growing infusion services at your health system, and how do you really implement this strategy? So I know it's cliche to use the iceberg, but there's a lot of unknown, and there's a lot of things that can impact the infusion ecosystem. Aside from, you know, Dale saying new drugs, aging population, a lot of payer restrictions. We know a lot of the payer restrictions that are on the surface, right? So white bag, site of care, payer vertical integration, and them having their own provider resources. We also know healthcare is consumer driven. It has to be about the patient experience and their customer service. But there's a lot of undercurrents or a lot of things that have the potential to impact the infusion service line that we don't necessarily have control over. How can we leverage AI, or payers leverage AI to appropriately direct care. What is site neutrality going to come down? There's new regulations potentially with 340B and their program changes. And then we know that for-profit and capital venture are jumping into this. So what can you really do to navigate this landscape? So again, infusion really should influence your organizational strategy, and it has to be a balance because care and the decisions have to be local, but you also have to have a coordinated strategy. So my biggest piece of advice is really tap into data. If you're going to invest anywhere, the infusion service line is not like the inpatient cost savings DRG driven service line. It's separately reimbursable. So understand your current state, know that your drug expense may go up, but know that you should be making money on that and have that separate. We have a separate scorecard to specifically look at infusion. The other thing that this allows us to do is pivot pretty quickly to understand what is the current impact of some of these undercurrents and some of these unknowns. If this were to change today, what would that look like across the board, across all your infusion services? Next slide, please. Just to talk about a little bit of our journey on how we did this. So we started our journey in 2021, and first we wanted to track and trend what's going on. We've engaged a consultant, Visant, to help us really navigate what's our opportunity, where do we go. In 23, we established governance. In 24, we really focused on building infrastructure, capital investing. And then in 2025, we looked at, that's our growth plan. This is our growth year. How do we expand our footprint and how do we capture those patients? This is very similar to something that you saw Jason put up, and it's that multi-pronged approach. Putting in alternate site infusions for us was an expansion. It's not cannibalism of your hospital-based. We didn't see a shift from our hospital-based infusion services over to hospital-based competition. We've asked a lot of other peers. They've experienced the same. We know that there's financial value in doing this. We know there's clinical benefits. Again, I named some of them, everything within Epic, being able to give the patient timely care, but then it's also about the patient experience. Then last slide, please. If you think about some of the strategy and some of the elements about dipping your toe into the alternate infusion strategy, again, you have to base it a little bit on local decisions. What does your current facilities look like, and what is your health system footprint? What's your market competition look like? What are your payers doing? What experience are you having? Are you at capacity in your current infusion centers? Is it easy for patients to get in and out of your hospital-based infusion centers, or would they think it's easier to go into an ambulatory infusion suite or a physician office? It's also, do you have the ability to transfer your nursing resources or your support staff throughout your different infusion sites? You know, we still are experiencing nursing shortages, and we are working on productivity. And then is your pharmacy structure centralized or decentralized? So do you have the ability to evoke this multi-pronged strategy, or is it going to take a lot of local small pieces and parts? And that's okay too. You just have to factor that in. And then also, what are the health system home health capabilities or your alternate infusion capabilities? Do you have these own services that are employed? Are you going to have to partner? There's a lot of vendor partners out there that can help you with your strategy. So all good things to consider, but I definitely would leave you with the parting thought of consider a non-hospital based infusion strategy. So I think, Dale, I'll pass it back to you.
Yeah, thanks, Amanda. So, you know, between Jason and Amanda, just a ton to think about and a ton to chew on, and it can seem overwhelming. And infusion is a niche enough area of the business that it can be very complicated. And you know, looking at Amanda's iceberg slide, she's right. What lies beneath is sometimes can feel overwhelming. And so where do you start? How do you think about getting into this, and what are the best approaches? And so I'll kind of talk through how we think about getting alignment within the organization and then getting down to yes, we're ready to go. We want to implement this to create a better experience for our patients. And so really one of the things Jason and Amanda and I talked about was you have to have that shared goals mindset within the system. Does everybody agree that the current process for infusion care is somewhat fragmented within the system, that it's difficult for providers and patients to navigate, and that there is a problem and a solution that you can solve to bring better outcomes and opportunity within your health system? I think we've found overwhelmingly across the country that rings true almost 100% of the time. Everybody sees a very similar thing in any part of the country that they're at. And the way Infusion operates, it's a small percentage of the overall business, but it is so very complicated that everybody wants to figure out a better solution for those patients. From there, you have to really understand current state process. Amanda and Jason did an amazing job talking about that centralized medication access process. And you can see, what Amanda walked through with what her team is doing. That takes time and a lot of infrastructure to build to be very good at that process. And if your current state is very fragmented and you don't have that, you're going to have a lot of frustration points. But that's very hard to gather. You're talking to a lot of different care teams and clinical areas. You're looking at all of your different infusion assets, potentially many different departments, from revenue cycle to the care teams to pharmacies could be touching this in a lot of different ways, whether it's take home, medical, infusion. Oftentimes we see it everywhere. And so that can be a very cumbersome undertaking. But once you have that shared goals mindset, you can start to uncover what your current state looks like so you can move into best practice. From there, you really got to look at the data. So Amanda talked about the value of understanding your data and what's happening. And it's not just the external forces like payers and 340B opportunities, but it's also your internal data. What is happening with those patients today? Are they leaving the system? If so, where are they going? And why is that happening? And what are those breakpoints within the process that cause that? And that is really something you have to hone in on in order to show the opportunity within the system. And to Amanda's point, and we can't stress this enough, what we're talking about with alternative ambulatory infusion sites, whether it's through pharmacy or others, is absolutely not meant to be cannibalistic with the existing business. And it really is meant to provide additional access. And there's plenty of business that's probably walking out of the four walls of your hospitals today. You're working on bringing that in, and you're going to need additional sites to accommodate all of that new volume. So it is mutually beneficial, and it's something that all systems need to understand and really rally around. So finally, you got to outline those recommendations and talk about the benefits to the system financially, patient care. There's a huge provider benefits to this. I can't stress that enough. And then, of course, clinical. And so, whether you have the expertise in-house to maybe manage all of this, that would be great. It's a good place to start. Oftentimes, as Amanda and Jason talked about, you may need to leverage some external support to help you organize the process, ask the right questions, and really outline what that opportunity is to help drive speed to value in order to stand up some of these operations. So that's kind of what we see as the best practice on next steps if you're really looking to engage in this type of an activity. And I would say if you don't currently have pharmacy infusion suites, or if you're not looking at different or better ways to leverage your infusion services strategy, this is a great place to start. And talking to folks like Jason and Amanda would really benefit your system with the experience that they've had.
Thank you, Jason, Amanda, and Dale, for a great discussion today. We will now begin today's Q&A. Audience, please feel free to submit your questions via the Q&A box on your screen. Let's get started with the first question. What would you say is the most important way to improve the patient journey without increasing the burden on the provider team?
Yeah, I think I can take that one, and most certainly, welcome Amanda and Dale to, jump in and supplement my comments. I would say the first part, would be to invest in some type of centralized med access team, differing sizes, shapes, whatever that looks like, but having that expertise that can navigate the authorization process. I think you heard Amanda and I both talk about we're in probably different spaces in terms of the AIS journey, kind of that third leg of the infusion stool. I think we both agree that that's a important part of the infusion strategy to keep patients within the system due to site of care restrictions and due to the the ease of scheduling and continuity of care. And then you saw Dale's slide from a marketplace perspective. There are a number of players in the home infusion and AIS suites. And those patients are your patients. They're our patients. Those aren't just random patients that these businesses are built off of. So, you're really bringing your patients back into your system by having those other options. But, the first step, I think, is that authorization process, right? So better provider benefits, not having the administrative burden for the docs, better patient experience, getting their medications or their infusions quickly. And then I think one of the best pieces of that is the ability to coordinate and navigate financial assistance, right? The out-of-pocket costs for specialty medications and infused medications is real for patients, regardless of whether you're an HMO or high deductible plan. And so having somebody that understands that can navigate them to foundation, manufacturer assistance programs, whatever is better for the patient, I think provides the most benefit and is applicable, whether it's a single state system like myself, or whether you're navigating a multi-state system like Amanda. I think that provides tremendous benefit for the patient and provider.
Thank you, Jason. We'll move on to the next question here. How can implementing an infusion as a service model within a holistic care framework help healthcare organizations retain patients and prevent them from seeking treatment elsewhere?
Sure. I think I can get us started and invite others to comment as well. Really, it's about creating and continuing to generate that patient loyalty and providing care to each instance of that patient. So they know if they're using their online portal, they know where to see their appointments. They know they're familiar with the buildings. It helps keep all the care team on the same page. Jason pointed out, financial assistance. Going to that one hub of care really offers a seamless patient experience within their existing healthcare home. And that all of their physicians, all of their care team are able to see that patient's care records. And I really liked what Jason said is those patients that are going to those external non-healthcare system owned facilities, those are our patients. And so we can provide that holistic experience. It aligns with value-based care and accountable care organization goals. And it also retains the revenue within your health system as well. So I would really, really say that providing that full spectrum of service really enhances your patient loyalty and stickiness to the health system.
And thank you, Amanda. I think we have time for one more here. So there's a concern that expanding into home or ambulatory infusion services could erode HOPD volumes and negatively impact financial performance. What has your experience been in this area? How do you manage essentially having a foot in both models without compromising either strategy?
Yeah, and maybe I'll start and would welcome Amanda and Jason because I know they have experience in this as well. I would say that is something that we hear very often from systems that we engage with across the country is not only are you going to be taking business out of our profitable HOPD locations and moving them into other locations erroneously, but also are you going to create site neutrality within our payer contracts? Is this going to cause them to say, great, you've got these other lower cost sites of care, we're no longer going to reimburse you at these higher rates on the HOPD? And what I can tell you is we haven't run into that yet across the country, both scenarios. One, and as we talked about, really the cannibalism within internally, we're not seeing that. There's enough business that's leaking today that's going outside of your system that the goal and the effort isn't to touch existing patients. It's to go after those patients that are leaving your system. So that checks that one off the box. And then from a site neutrality perspective, we just haven't seen that come to bear. There's plenty of opportunities for these patients to be seen in the higher acuity model within HOPD. And those are really the patients we want there. Initial starts, maybe more fragile patients. That way your system can see more of those patients. And then those patients that are eligible for a lower site of care, it probably is a better site for them. It can be more convenient. They don't have to pay for parking at a main hospital campus potentially, right? It makes it a lot easier for them to actually get and receive care. And ultimately, it makes the access equation very simple. And so it frees up this accessibility for your patients, which Amanda talks about this a lot. Huge patient satisfier. This is what they want. This is what they're asking for. It will drive retention and hopefully acquisition of new patients by doing that. So we have not seen an issue with these models. And if anything, we're seeing systems become very strategic with how they manage across all of these different sites of care, and whether they're using site neutral split billing in certain locations or pharmacy ambulatory infusion suites, and how they move their patients. But using that central med access process is really key to making sure that you're moving patients to the location that makes the most sense based on your fundamental triage of support structures, whether it be financial or patient need or payer driven. You have a team that can help you navigate the intricacies of that, and then making sure you have that holistic site of care footprint gives you the ability to really over index on the patient and provider experience to make sure that payers ultimately want the same thing you do: better care for patients at a lower cost. They're not looking to disrupt the apple cart. They're going to do it for you anyways. It's best to have the process to manage as much as you can and really internalize that leakage.
Awesome. Thank you, Dale. That is all the time we have for today. So I want to thank Jason, Amanda, and Dale for an excellent discussion, and also to Vizant for sponsoring today's webinar. Don't forget to fill out the webinar survey found on the right-hand side of your screen before logging off. We would love to hear your feedback. Thank you again for joining us, and we hope to see you at future sessions.